My father would be so proud, seeing as I'm not a doctor. He wanted me to be a doctor. It was his lifelong dream for me to be a doctor. And I remember a time he picked me up from school, and he was with his best friend, who was also, he also had a daughter in my school who was a couple of years behind me. And we were not friends, this girl and I. She was a couple of years behind me, and she had a reputation for not being very smart. Now, our school had this system where every month they would, at the assembly ground, publish the names of the top 3 performers and the bottom 3 performers. So you wanted to be in the top 3. You could even have your name not mentioned, but you didn't want to be in the bottom 3. And she was consistently in the bottom 3. So our dads picked us up, and they asked, "How did you do?" And I said, "Oh, I did well." And then they asked her, "How did you do?" And then my dad's friend said, "Why even asking? She came last. She always comes last." And then my dad parked the car. He turned around and looked at us and said, "What's your plan?" And I said, "I do not have a plan." He said, "You don't have a plan. You're just smart for nonsense." And I looked because I didn't know I had to have a plan. I just thought I should be smart. And then he asked her, "What's your plan?" And she said she wanted to be a nurse. And his friend said, "She won't be a nurse. She's not smart." And my dad said, "That's disrespectful to her and to you." And he said something to her in their language that I never really understood. I didn't know what he said. But the next term, something happened, and this girl was in the top 3. And consistently till I graduated, she was in the top 3. And she went on to becoming a nurse. And so I used to wonder, what is it about her? What changed? And I discussed it sometimes, and some people said, "Oh, maybe it was just time." But someone said something that stuck. They said, maybe for the first time, someone believed in her. Maybe she believed in herself. And I thought of this for a long time, because until that time, I still did not have a plan. I just knew that I was going to be a doctor because my father said so. So after secondary school, I was teaching for a couple of months in my mom's school. And it was a nursery school, and this man brought in 3 children to the school. They were all below the ages of 5, 2 boys and a girl. The girl was the smallest. And he came in and he asked after fees, and he left, saying he couldn't afford to pay fees for all 3 of them. And so he walked to the gate, and he drew a line in the sand. And he made the children line up. And he went to the wall, and he raised his arm. As soon as he put his arm down, the kids started to run. And we were wondering, why are they running? What's going on? And he came back to the office and said, "The 2 boys go to school, the girl stays at home." And we said, "What helped you decide?" He said, "Oh, I made them race for it. I told them that the first 2 get to go to school. The last one stays at home." Now you would think he gave the girl a fair chance to go to school, but she was the youngest. She was the smallest. So the odds were stacked against her from the word go. And she would stay at home through no fault of her own. But someone would say, "Oh, she was given equal opportunity with the boys, but she was at a disadvantage." At that point in time, I realized I did not want to be a doctor. I wanted to work where I could create equal opportunity. I could build an environment for women and children to thrive, to live to their fullest potential. But I love healthcare, and so I thought I should work in something that expands access to healthcare. And what better opportunity than public health supply chains? My job basically entails making sure that people get medicines and the health services that they need when they need them. Now, this is not always easy because, as a speaker mentioned before, we are the poverty capital of the world. So we depend a lot on foreign aid. We depend a lot on donated medicines. And malaria, HIV, tuberculosis are diseases of poverty. So not only are we poor, but we're saddled with diseases as well. And I remember one time where it was one of the first few visits I made to a village in Bauchi State, which is in the northeast. And it was just when Boko Haram had just started. We hadn't started to really hear of them really operating, but they were practicing. And I was in a public health facility, and we had taken contraceptives to that clinic. And suddenly, we heard motorcycles and cars, and two nurses came in and said, hide in the toilets. Boko Haram is here, they're going to kill you. And I locked myself in the toilet, and I thought, is this how I die? Next to a box of condoms? And I went back, and I thought to myself, I don't know if this is worth it. Maybe I need a desk job. Maybe I should look at policies. And as I was trying to convince myself, I went to another clinic. And this was at the time of cholera. And we had dropped their supplies, and we're about to leave when this Kekena Pep comes to the clinic, and they bring out this woman. And she's heavily pregnant, she's bleeding, she's throwing up, and 3 young boys are pulling her out of the vehicle. And they put her on the corridor. And this nurse comes out. And she looks at her, and she taps her with her foot. And the woman is unresponsive. The only thing she does is sometimes she raises herself and throws up. But she's in pain. You can see she's bleeding. So I come and I'm like, why aren't we helping this woman? Let's help her. And the nurse looks at me with disdain and says, where are the gloves? If she has cholera, I'm not touching her without gloves. We don't have medicines, we don't have infusions, so she's going to die. And I don't want her to die here because she'll infect the other people. So let's tell these boys to take her to the general hospital. The general hospital was 2.5 hours away. And so I thought, we die here. We will make sure that as much as it depends on us, we will try to make sure that we have better policies, better distribution networks, and better accountability so that we can make sure that medicines reach sick people when they need them. And this was fine for a while, and I was motivated, and it was nice to know that the malaria medicines, HIV medicines, medicines for tuberculosis were reaching PHCs. But then there was a 2013 survey, national survey, that said majority of the Nigerian population don't go to public health facilities. It's either because they can't afford it, they don't have the transportation, there are no skilled staff, and some people still have to take permission before they even reach those facilities. And so we started to look at the private sector. Now, most of us go to the private sector. I'm willing to bet that most people in this hall, when they have a headache, when they have a fever, their first thought is not, let me go to the hospital. Their first thought is, let me go to H-Medics or the closest pharmacy. I'll buy myself. I know my body. This is malaria. My mouth is bitter. This is how it used to do me. We know ourselves. But you see, we are the privileged. In remote communities, they don't have that option. So they go to traditional healers, or they pray and say, if the child is strong, if it's ordained that the child will survive, she will survive. Otherwise, we will get more. We say, oh, the woman, she's strong. If she's going to survive childbirth, she will survive childbirth. But that doesn't cut it. And so we worked on the private sector and started to engage patent medicine vendors who are available in almost every community across Nigeria. And in other places, we looked at other community resource people that could look at a child, assess for clinical signs, and then treat for basic uncomplicated illnesses or refer to public health facilities or general hospitals. And this was working. We found that with the proper training, these people could recognize pneumonia, signs of pneumonia, and treat at home so that they did not have to go to the hospital or to the clinic. And so the chances that a child will survive are higher. Unfortunately, even with the medicines and the proper training, a lot of people cannot afford these medicines. A lot of people cannot afford to take a test for malaria. So they would rather prefer preemptive treatment and say, okay, I think this is what it is, and I will pay you. And PPMVs themselves don't stock expensive medicines. And so this is a time where we realize that we're at a cross-section in our healthcare system where the donors are doing their bit, supply chains are doing their bit, the government is doing their bit, and it's now time to work from the bottom up as well and look at what we can leverage on within our systems that can improve our own health. For example, when it's time for a wedding, we all are very interested in our children. We want to contribute, we want to buy the fabric. We have meetings, we have regular women's meetings, and we keep fighting for equal opportunity. And we need to look within ourselves and start thinking of equal responsibility as well. What can we do? What can we harness? Recently, there was a workshop, a national workshop on traditional medicines. Can we start to manufacture these medicines locally so that the prices are reduced and people can afford them? Can we in our communities start to contribute towards our own health so that when someone is getting married, instead of the fabric, we're thinking, oh, okay, this is where you are now a member of our health insurance scheme, our community village health insurance. When you have a baby, we take from your contribution and we give it to you to buy health supplies. Or at our meetings, we make a contribution and we dig a borehole so that we can have safe drinking water. What are we going to do for our children? Are we pooling funds for this?